So today my topic will be how to deal with raised figures in a walking patient. तुमच्याकडे ओपीडी मध्ये एक पेशंट येतो, त्याचं बीपी वाढलेलं असतं. इट इज अ रेस्ड फिगर ऑफ ब्लड प्रेशर. कोणीतरी येऊन तुम्हाला शुगरचा रिपोर्ट दाखवतो की माझी शुगर वाढली आहे. समबडी सेज की माझं कोलेस्ट्रॉल वाढलंय. समबडी सेज माझं थायरॉइड वाढलंय. यावेळी करायचं काय? आपण प्रत्येक पेशंटला रेफर नाही करू शकत. प्रणव आडकर इतकं पोटेन्शियल प्रत्येकाकडे नसतं. प्रणवला आता फिजिशियनला रेफर केले, न्यूरोलॉजिस्टला केले, न्यूरोसर्जनला रेफर केले, ऑर्थोपेडिशियनला केलं. त्याला फक्त गायनेकोलॉजिस्ट आणि ऑब्स्टेट्रिशियनला पेशंट रेफर नाही केले. So we are in such a situation that we have to deal with the patient who is a walking patient in your OPD and he is having some raised figures. And all the time you can't refer the patient, but how to deal with that? You should know something about all these raised figures, and that will be my topic today. Definitely I will be try to keep it in time. First of all, how to deal with raised blood pressure. In the raised blood pressure, there should be 3 steps to deal with that. You just recheck and confirm. एकदा बीपी वाढलं म्हणून त्याला लगेच ब्लड प्रेशरची गोळी द्यायची असते असं डेफिनेटली नसतं. ह्याच लॉजिकवर आज आपण पुढचे एक 7-8 मिनिटं बोलणार आहोत. देन चेक बीपी इन डिफरंट पोझिशन्स. Yes, there is definitely you have to check the BP in different positions, in lying down position, in sitting position, both the extremities. या both extremities मध्ये वेगवेगळं ब्लड प्रेशर मिळू शकतं. And then try to locate की काय नेमकं चाललंय. खरंच ब्लड प्रेशर वाढलंय का? Whether the raised blood pressure is requiring any sort of intervention or the treatment or the evaluation for that. And then look for situational or emotional reactions. Is there any stress induced? Is there any acute situational reaction going on? Because the raised blood pressure will be primary and secondary. The percentage of the primary raised blood pressure will be high and the secondary will be low, but they will be categorized two different blood pressures, raised blood pressures. Primary raised blood pressure may be essential or the genetic polymorphism. In the secondary, there are n number of causes which are renal, cardiac, peripheral, thyroid diseases, obesity, syndrome, like that. You have to deal with की काय चाललंय. हे प्रायमरी आहे का काही रिव्हर्सिबल कॉजेस आहेत, काही सेकंडरी कॉजेस आहेत. दॅट वी हॅव टू ट्रीट. हाऊ द प्रणव ऑलरेडी टोल्ड की एक रेज्ड इंट्राक्रॅनियल टेन्शन घेऊन आलेला होता. Now this raised blood pressure can be presented in some different scenarios. First is raised systolic and normal diastolic. Second is raised systolic and lower diastolic. That is a wide pulse pressure. Third one will be raised systolic, raised diastolic, and the last one will be normal systolic and raised diastolic. ओके, या 4 प्रकारे तुमच्याकडे आलेला रेस्ड ब्लड प्रेशरचा पेशंट तुमच्याकडे येणार आहे. हाऊ यू आर गोइंग टू डील विथ. मी कुठली थेरी रेफर केलेली नाहीये, कुठले गुगलवरचे रेफरन्स दिलेले नाहीयेत, कुठलं अप टू डेट घेतलेलं नाही. मी माझी थेरी मांडली, मला जशी वाटते तशी. ती तुम्हाला जशी जमेल तशी घेऊन जा, एवढंच माझं विनम्रपणे म्हणणं आहे. रेस्ड सिस्टॉलिक, नॉर्मल डायस्टॉलिक इन एल्डरली इट मे बी ट्रू. In young, it may be momentary, false or white coat hypertension. The first line treatment will be chlorothiazides, calcium channel blockers and ARB. And second line you can add the beta blockers. In the raised systolic and lower diastolic, the wide pulse pressure may be in elderly due to anemia, hypothyroidism, peripheral AV malformations. There may be some aortic wall lesions. In young, it is AV shunts, severe endocrinopathies. First line is AC inhibitors, ARB, AB. That is alpha blockers, and second line will be again calcium channel blockers. In raised systolic and raised diastolic, definitely it is a cognizable blood pressure that you have to deal with and go for in the elderly, whether it is a PVD or the vasculopathies, atherosclerotic or stiff vessels, increase after load of the heart. In the young also it will be same because both systolic and diastolic both will be raised and it will be significantly or highly raised blood pressure. It will definitely require some treatment and not the ignorance or not to wait. First line again will be calcium channel blockers. You can add on therapies, and second line also you can add some of the other drugs. In normal systolic and raised diastolic, it may be idiopathic or the stenotic wall lesions in the elderly, and in young it may be again idiopathic or less common. First line treatment will be ARBs, low dose CCBs, and second line will be combination. ब्लड प्रेशर 4 प्रकारे वाढू शकतं. फक्त वरचं की फक्त खालचं, फक्त सिस्टोलिक की फक्त डायस्टोलिक, याचे 4 वेगवेगळे सिनेरिओ आहेत. याचा मतितार्थ शेवटी मी एक वाक्यात सांगणार आहे. बट टू रिमेंबर फॉर द बीपी रिडिंग्स दॅट बीपी टार्गेट एज पर JNC 8 guidelines, the BP target is less than 140/90 and in elderly it is less than 150/90. If BP fluctuation is more than 30 millimeter of mercury in 30 minutes, then mostly it is momentary. Go for the ambulatory BP monitoring if it is first time detected and your walking patient is not a known case of hypertension. And hypertensive emergency is blood pressure more than 180 by 120 with the three subsequent readings. Now, evaluation and counseling, you just go for the past history की patient ला already काही BP ची गोळी सुरू आहे, whether he or she is a drug defaulter. Then ambulatory BP monitoring, you can evaluate for the CBC, RFT, lipid profile, TFT, urine routine. Most of the time, the patient presented with the raised blood pressure first time and the patient is young. Then your target organ may not be your heart or the brain, but it may be kidney. That's why you go for the primary evaluation of some blood tests, then ECG and 2D echo, renal Doppler and sonographies, and how to deal with the counseling, that acceptance, that there should not be denial of the hypertension itself by the patient side. Then diet modification, lifestyle modification, regular monitoring, regular medications, all these things that you all of know. Now, how to deal with the raised blood sugar levels. So while going for the raised blood sugar levels, points to remember are don't treat random figures. Recheck and confirm with BSL fasting and postprandial. You confirm with HbA1c and urine routine. Again, you will have some BSL readings that raised fasting and normal postprandial, normal fasting and raised postprandials, and raised fasting and raised postprandials. The readings may be, I have differentiated की fasting फक्त वाढलं किंवा फक्त postprandial वाढलं किंवा दोन्ही वाढले तर कसं. But note it, in the first scenario there is increased hepatic glucose output. And the treatment will be metformin, SGLT2 inhibitors, basal insulin if uncontrolled. In the second scenario, post-meal glucose spike will be there. The Voglibos, DPP4 inhibitors, GLP-1RA, if the patient is obese, are recommended. And in the third scenario, insulin resistant with deficiency, and definitely we will go for the metformin and add-on therapies, metformin plus DPP4 or SGLT2 and basal bolus insulin. अजून सोपं सांगू का, आपल्या शरीरामधलं पॅनक्रियाज इन्सुलिन रिलीज करतं, ते इन्सुलिन तुम्ही खाल्लेल्या प्रत्येक गोष्टीची जी शुगर होते त्याच्यावर जाऊन काम करतं. जिथे इन्सुलिन तयारच होत नाही तिथे त्या शुगरवर जाऊन काम होणार नाही. तुम्ही शुगर चेक केली ते वाढलेली दिसेल. किंवा जे इन्सुलिन तयार होतं ते इन्सुलिनची पोटेन्सी कमी असते आणि ते जाऊन त्या शुगरवर जरी काम केलं तरी त्या शुगरचं एनर्जीमध्ये कन्व्हर्जन करता येत नाही आणि मग तिथे तुम्हाला शुगर वाढलेली दिसते. असा या सगळ्या चार्टचा अर्थ आहे. आणि मतितार्थ असा आहे, फक्त एक रिपोर्ट वाढलेला असला म्हणून तो ट्रीट करू नका. त्याचं फास्टिंग पीपी बघा, HbA1c बघा, रिकन्फर्म इट अँड देन गो फॉर द ट्रीटमेंट. Rationalized approach will be pre-diabetes lifestyle modification for 3 to 6 months. Confirmed diabetes, metformin if eGFR more than or equal to 45. Avoid hypoglycemia prone drugs initially. Specialized approach if HbA1c is more than 9% or complicated diabetes or the complicated raised BSL readings. Common mistakes while dealing with the raised BSL is starting drugs for borderline values, ignoring history of stopped medications, sulfonylureas as first line therapy, and treating reports and not the patients. Now raised lipids, Benny. Yesterday, Benny and Ambika had some good conversation in between, but both of them forget. Always the physician is a Mandoli Badshah. You have to deal with the physician. Yeah, everybody will agree with me as we agreed with the Benny yesterday that profiling of lipids, this is LDL, HDL, triglycerides and total cholesterol. Of course, LDL is a bad cholesterol, HDL is good cholesterol. Triglyceride is a combination of glycerol and 3 fatty acids, and total cholesterol is a overall cholesterol combination of LDL-C, VLDL-C and HDL-C. The causes in the LAD we have discussed a lot, but just to start, the drug of choice is statins. In HDL, lowers the risk of heart disease, it will carry extra cholesterol and delivers to liver and removes out. In the triglyceride, increase the risk of pancreatitis, and drugs of choice are fibrates, omega-3 fatty acids. And in the total cholesterol, again the drug of choice is statins. त्यामुळे तुम्हाला ट्रायग्लिसराइड वाढले असेल you can go for the phenofibrates. In the LDL and cholesterol you can go for the statins. पण the most important message through this raised lipid is that don't treat the figures. You treat the raised lipid or the raised cholesterol levels as a signal to go for the cardiac evaluation. And I hope not Abhijit Joshi, Akshay Kasid, Abhay Khode and Benny Jose had GP'd me, but still I am saying it. But this very simply, without again referring for any theory, this is my theory, that you apply the rule of 50 to your lipid profile reports. Your SDL should be more than 50, your LDL should be less than 100, your triglyceride should be less than 150, and your total cholesterol should be less than 200. It's a simple rule of 50. Now, what are the precautions for the dyslipidemia? Again, the low-fat diet, physical activity, regular checkup. Avoid alcohol and smoking if you are not in the premises of Ambe Valley and if Dr. Prasad Biware is not on the stage. And now my last point is deranged RFTs. Deranged TFTs, thyroid functions. Again, going forward, that what are the thyroid dysfunctions? If you consider this scenario tabulation, the 15% are the goiter or which we deal with the variable readings of the thyroid, that is T3, T4 and TSH. In the second scenario, there is hypothyroidism, where is the low TSH is there and raised T3 and T4 is there. It is hyperthyroidism. Third scenario, it may be thyroid cancer or some other abnormalities. There you get the usually normal values of T3, T4, TSH. But where you get the raised TSH, low T3, T4, that is hypothyroidism. We are dealing with the raised figures, not the lowered figures, to conclude more with my almost last slide. These are the conditions: hypothyroidism, hyperthyroidism, goiter and thyroid cancers. These are the common causes like Hashimoto disease, Graves' disease, iodine deficiency, inflammation, genetic environment. These are the some symptoms that patient may present with fatigue, weight gain in the hypothyroidism, unexplained weight loss, rapid heartbeats, or the anxiety-related tremors in the hyperthyroidism, swollen neck in the goiter, and painless neck lumps in the thyroid cancer. The complications we all know, but the treatment will be in the hypothyroidism, it will be levothyroxine and the thyroxine. In the hyperthyroidism, it may be neomercazole or the beta blockers. In goiter, it may be radioactive iodine, and the thyroid cancers, it may be thyroidectomy. And what are the red flag symptoms for the raised thyroids? Raised T3, T4 or TSH. Myxedema coma, that is a life-threatening emergency due to severe long-standing hypothyroidism. Thyroid storm, that is acute life-threatening exacerbation of severe thyrotoxicosis. Bradyarrhythmias or tachyarrhythmias, which may present with some raised figures of T3, T4 or TSH. And the fourth one is altered sensorium. It generally doesn't happen in a walking patient, and we are talking about the walking patient. It just to convey some messages through this topic. Now, what will be the take-home message again? First one is, calcium channel blockers are most safe antihypertensive to use in many conditions. Disclaimer is, there are some different indications and different scenarios where we have to use rest of the antihypertensive drugs than calcium channel blockers, but in any condition, the most safe, not the safest, but the most safe is the calcium channel blocker. Second one is, don't treat random BSL if confirmed by BSL fasting PP, HbA1c and urine routine. Till cardiac evaluation is mandatory before treating dyslipidemia. Monitor TFT's lipid profile every 3 months in newly detected or unknown case. I know that to conclude this, I have to say something poetically, but this time I am not going to have a poem. मैं कुछ दोहे रख दूंगा, दो लाइन के. वाढलेल्या आकड्यांचा करू नये उपचार, पुन्हा एक वार तपासावे. Because the way I am putting the table, that RCA, that is R for recheck, C for confirm and A for assurance. And that's why I am saying की वाढलेल्या आकड्यांचा करू नये उपचार, पुन्हा एक वार तपासावे. रक्ताचा दाब कायमिकी फुकाचा, रक्ताचा दाब कायमिकी फुकाचा, विचार टोकाचा करू नये. साखरेचा गोडवा दाविता अंतर, साखरेचा गोडवा दाविता अंतर, आधीनी नंतर तपासावे. असंतुलित होतात चरबी रक्ताची, असंतुलित होतात चरबी रक्ताची, तपासणी सक्तीची, म्हणजे कार्डियाक इव्हॅल्युएशन वेरी. असंतुलित होतात चरबी रक्ताची, तपासणी सक्तीची करू जाणे. ग्रंथीचे विकार नाही गणिताचा खेळ, ग्रंथीचे विकार नाही गणिताचा खेळ, नीटसा मेळ बसविणे. आणि फारच वेगळे वाटता आकडे, फारच वेगळे वाटता आकडे, सत्वर मजकडे पाठवावे.